So if you look on your program, this is the systemic therapy section, and we just completed the local therapy section. I hear the bells going off in the back. So I'm going to go ahead and introduce our speakers. Okay.
Should have never given us.
I know. It's like getting you guys together for tumor board. Yeah. Okay, so our first speaker for the systemic therapy section is Leo Mascarenhas. Leo is the Deputy Director of Children's Center for Cancer and Blood Diseases and the Section Head of Oncology within the Division of Hematology Oncology and Blood and Bone Marrow Transplant at Children's Hospital, LA. Dr. Mascarenhas is an Associate Professor of Pediatrics in the Keck School of Medicine, University of Southern California. He's also an attending oncologist in Division of Hematology, Oncology and Blood and Bone Marrow Transplant at CHLA. He holds the Associate Sarcoma Program Endowed Chair and is the Director of the Sarcoma and Solid Tumor Program at CHLA. Dr. Mascarenhas is an internationally recognized expert in pediatric bone and soft tissue tumors. His research focuses on clinical trials for sarcomas in pediatrics, adolescents and young adults, as well as developmental therapeutics for pediatric solid tumors. He is the principal investigator of the National Cancer Institute-funded Children's Oncology Group, COG, and NCI's Pediatric Early Phase Clinical Trial Network Consortium at CHLA. He is the elected chair of the voting body of COG and also serves as a member of the Bone Sarcoma and Soft Tissue Sarcoma Scientific Steering Committee for COG. Dr. Mascarenhas is certified by the American Board of Pediatrics and General Pediatrics and Hematology Oncology. He has received several teaching and mentoring awards and has been continuously recognized by the best doctors in America of Pasadena and the Los Angeles top doctors as well. Dr. Mascarenhas joined Children's Hospital in 1995 for his fellowship and has been on the faculty since 1998. Dr. Mascarenhas received a bachelor's degree from St. Joseph's College of Arts and Science and a medical degree from St. John's Medical College, both in Bangalore, India. He also has a master's degree in clinical and biomedical investigations from the Keck School of Medicine and University of Southern California. So to talk to us about general therapies, right, general systemic therapies, and also the clinical trials, here's Leo Mascarenhas.
Still morning, so good morning everyone, and thank you James and David for inviting me to speak at this wonderful symposium today. And I'm also very grateful and privileged to really be here in honor of David Stroud. I helped take care of him many years ago. And one thing which I'll vouch for is even though he was very sick in hospital, when I saw him on rounds every day, he made me smile. And that's the kind of guy he was. So what I'm going to do over the next 20 minutes is really do a little bit of a whirlwind because I think it took me much longer to prepare for a 20-minute talk to distill all the information which would be there to actually give this particular talk. These are my, that was too fast, sorry, these are my disclosures. I was briefly on a speakers bureau for Bayer. I'm going to not be speaking about off-label use of medications, but some of them may be implied with some of my presentations, and the other are all my investigation roles outside CHLA. So I was going to focus on the pediatric type sarcomas, and these are most of the sarcomas in the AYA age group, so they're very relevant to the discussion today and set the stage for where we are with the treatment and what needs to be done to improve outcomes of these particular patients. And so the sarcomas which I'll talk about are osteosarcoma, which is the most common sarcoma in the bone, Ewing sarcoma, which is the second most common malignant sarcoma in the bone in this age group, but can sometimes, in about 20% of cases, occur in the soft tissues also. rhabdomyosarcoma, which is the most common soft tissue sarcoma in early childhood, in the first decade of life, and then slowly drops in the second decade and then becomes vanishingly rare after that, but still relevant because the older patients tend not to do well. And then synovial sarcoma, which is the typical AYA sarcoma, which occurs primarily in the adolescent and young adult age group, but really we see an uptick starting in the second decade of life as teenagers. So the standard of care for these with osteosarcoma is the one recurring theme over here, which you will see, is that the treatment for this disease, these diseases, hasn't really changed for about 30 or 35 years. And what we've really done is further refined through risk stratification and really try to limit some of the toxicities in patients who have an excellent prognosis. But we really haven't made a dent in patients who present with metastatic disease or patients who relapse after primary treatment. So the standard of care in general for osteosarcoma is chemotherapy and surgery, and chemotherapy includes cisplatin, doxorubicin, or high-dose methotrexate, which is usually administered over a 30-week period. And surgery is typically done after about 10 weeks of neoadjuvant chemotherapy. For Ewing sarcoma and PNET, this was distinguished from osteosarcoma and really being a radiation-sensitive tumor when it was first diagnosed. So we can add radiation therapy to the armamentarium for the treatment of this disease. The standard chemotherapy is vincristine, doxorubicin, cyclophosphamide alternating with ifosfamide and etoposide. And here patients are treated for almost a year with pretty heavy-duty chemotherapy. And after about 12 weeks, 12 to 15 weeks of chemotherapy, they either undergo surgery if possible, and then if the surgical margins of this residual disease, after that they receive radiation therapy. And if surgery cannot be performed, then radiation therapy becomes the standard for local control of this disease. On the other hand, rhabdomyosarcoma is again primarily treated with chemotherapy, and the standard treatment in North America is vincristine, dactinomycin, and cyclophosphamide. Rhabdomyosarcoma can occur in almost every spot in the body, and a lot of them actually occur in the head and neck and in the genitourinary region. And so therefore surgery is very challenging on those areas. Fortunately, this tumor is sensitive to radiation therapy. So radiation can actually be used for curative local therapy in this particular disease. Unfortunately, since a lot of these patients are young, the late effects of radiation therapy can be devastating in these particular patients. So it requires a lot of expertise in order to really care for these patients appropriately. And then for synovial sarcoma, again, the primary treatment is surgery if possible. Traditionally, radiation oncologists have always recommended adjuvant radiation therapy, but the more we've treated these patients uniformly, adequate surgery, if it's not metastatic, may be sufficient for these patients, particularly those with lower grade tumors. And chemotherapy is reserved for those who have large tumors which are high grade, who have a high risk of metastases, and they're primarily treated with either ifosfamide or doxorubicin and ifosfamide. Having said that, chemotherapy has not been shown to affect survival in this disease. So when you look at the outcomes of patients with localized disease, and metastatic disease, so this is very revealing. Like for osteosarcoma, the survival over here for patients less than the age of 18 is around, about 70%, and it drops to about 55% for those who are over the age of 18. And some of this is due to the biology of the disease, but some of it may also be because of healthcare disparity in the adolescent and young adult age group. The next, on the Kaplan-Meier curves on the right-hand side of the slide, this is a paper which was published based on SEER data and COG data. And you can see on this slide that if you have actually localized disease and if you're less than 18 years old, you have almost an 80% chance of being cured with Ewing sarcoma. But then if you have localized disease with a pelvic primary, or if you're over the age of 18 and white and non-Hispanic, then you also have a better survival. But when you have Ewing sarcoma in other races, or if you have Ewing sarcoma with pelvic primaries and metastatic disease, then you actually don't do as well, with the worst prognosis in patients who have metastatic disease and those who are over the age of 18 years old, which form the bulk of patients in the adolescent and young adult age group. And this same SEER data was basically, the same data was recapitulated with the Children's Oncology Group experience. So similarly for rhabdomyosarcoma, you can see over here that when you look at children have intermediate survival when you have localized disease, really with patients who are treated with standard therapy over here. But if you're an adult, so that's over the age of 18, the survival is actually quite poor. And interestingly, our Italian colleagues looked at all the adult patients who were treated with rhabdomyosarcoma, since this is a rare disease, and they were assigned a score of 1 if they were treated the way they were supposed to be treated. And if you, in this data, you can see if they actually got treatment similar to pediatric patients, they actually had a survival which was almost equivalent to pediatric patients. But very often they found that because oncologists and patients thought that the prognosis was so poor that they didn't treat them with the most effective therapy. They either skipped radiation therapy because they said it was not worth putting the patient through, or they didn't have surgery, or they modified chemotherapy in these patients. And when any of those things happened, the survival was poorer. When you look at synovial sarcoma, and this is data from the largest study, and this was conducted in children, adolescents, as well as young adults up to the age of 30 with synovial sarcoma, you can see that if you had low-risk disease, and these low-risk patients are patients who were treated with surgery alone, they have an excellent survival over here. And then the intermediate risk are the patients who did not have metastatic disease but received chemotherapy and radiation. They had a more intermediate survival. The challenge with synovial sarcoma, and even with Ewing sarcoma, though it's more common in synovial sarcoma, is that synovial sarcoma can relapse even 10, 15, 20 years later, which is very different from some of the other tumors where the majority of relapses will actually happen in the first 2 to 3 years. And then for high-risk disease, patients who have metastatic disease, their survival is very poor. So coming to relapse disease, Dr. Gainen, who is one of our senior oncologists and a humorous guy, sometimes would tell me, he said, lesson number 1 is don't get cancer. And the second thing is, if you do get cancer, don't relapse. And the reason is, once you relapse, your prognosis for most disease is actually quite poor. And it's the same story for sarcomas. You can see in this original paper where we looked at IRS patients, the survival really of patients who relapse, even at 2 years, is just only about 20%. Similarly, from Ewing's, this is for metastatic disease. This is not relapse disease. For metastatic disease at the time of diagnosis, for rhabdomyosarcoma, your survival is only about 20%, which means 1 out of 5 would survive. And this is a mixture of both the good prognosis and the poor prognosis patients. So if you actually have a fusion positive, your survival would be about 10%. Dr. Hellman would say it's 0 again, but really it's dismal. For Ewing sarcoma, we cure about 25% of them, and similarly with osteosarcoma, we cure about 20 to 25% of them. The story is the same for relapse disease, where you can actually see for patients with first relapse who were treated with chemotherapy, that these patients had a poor survival. Similarly, for Ewing sarcoma, the survival rate is about 12% at 2 years following relapse. And for osteosarcoma, the survival is less than 20% once you relapse. A big myth in the adolescent and young adult age group is that, they say, you pediatric oncologists treat those children with such heavy-duty chemotherapy, our patients are not going to tolerate it. And so we can't give them that treatment. But when we actually looked at older patients, and so look at this, and the reference over here are children below the age of 4, and then we divided the data of patients treated on IRS-4, which is not a study conducted by the Internal Revenue Service. It was the Rhabdomyosarcoma group. They broke them into these different categories of 5 to 9, 10 to 14, and 15 to 20. And this is, again, the adolescent and young adult age group. The incidence of neutropenia, anemia, thrombocytopenia, this is low white count, low hemoglobin, low platelets, and infection was actually a lot less than the younger children, which means the older patients actually tolerated this a lot better. The only difference was that, and we know this from practice, if you're an older patient, you don't tolerate vincristine very well, and you get peripheral neuropathy. Not only that, the incidence of mouth sores or mucositis because of chemotherapy, which is actually quite painful, almost never occurred in the older patients, but was much common in the young patients. So the lesson from this is that actually young children suffer the toxicity of chemotherapy a lot older, and we should be able to push our therapies, at least in sarcoma patients, a lot harder in the adolescent and young adult age groups. The story is not essentially the same for leukemia, but that's beyond the scope of this talk. And this was also recapitulated not by us in the United States, but this is also, oh my God, this is going the wrong way. This is also by the Europeans with Ewing sarcoma, where they looked at their trials where they actually treated patients up to the age of 50 on the Euro-Ewing trial. And you can see over here, when you look at the age group, that the story was exactly the same for all the hematopoietic toxicity, as well as vomiting, mucositis, and fever, that these patients actually had a lower risk. There was a trend to actually having improved outcomes in the older patients for these morbidities, and there was no difference in the incidence of diarrhea. So another thing which I wanted to talk about today is we learn and we've made progress by patients participating in clinical trials. And there are many other experts in this room who can speak more to it, but I thought I would just show you this data which was presented almost a decade ago at ASCO during an education session, which you look at the participation in clinical trials for bone sarcomas, and almost entirely the clinical trials are patients in the pediatric age group and young adolescent age group. And then the moment you look at the adolescent and young adults, their participation drops off. So oftentimes when we actually speak to people, they'll say, oh, there's no data. Why don't we have data? It's because adolescents and young adults are not put on clinical trials, and it's for various reasons. And to, again, speak about Dr. Hellman's point, it's all about access. So we really need to ensure that we actually have these trials for our patients to enroll on. And the story is exactly the same for soft tissue sarcomas, which is seen over here. So what guides our practice today? We can see various phase 2 and phase 3 trials guide us. There are numerous subgroups represented. Some are chemosensitive, some are resistant. We use various dosing schedules. And then we see whether a patient has localized disease or advanced disease, or if they have unresectable or metastatic disease. And we look at different endpoints like event-free survival or progression-free survival. We look at overall survival. We look at all odds ratios of response and overall response rates, and we also look at clinical benefit rates in our patients. That's what guides us right now in this day and time. But I think we've come to the end of the road, and it's time to question which direction we should actually move in to make progress. I just told you when I started my talk, things have not changed for the last 30 years. We've sort of fine-tuned it a little, but we've not taken that big leap forward, which we need to do. And so I think we can use sarcomas as a model to really study these and move the science ahead. And is this the right time to do it? And I think the answer is yes to that. We have lots of genetic information coming out, molecular genetic on these tumors, and that leads us to look at novel biology, which can lead to attractive drug development. We have open field application for new technologies and scientific advancement. There's an influx of new agents and trials everywhere, and there are different subtype trials now which could potentially be used for registration subtracts. There's so much of discovery in mesenchymal biology, and we know that it's not just the cancer cells, but the surrounding cells or the microenvironment in which these cancer cells actually thrive in are being supported, and perhaps we can target that. And I think these discoveries in sarcoma can then go on to actually inform decisions in other diseases. And so, when you talk about sarcomas, particularly sarcomas in the advanced age group, I spoke about 4 of them to you. There are over 200 different subtypes of sarcomas, and each one of them is different. And we lump them all together, and we treat them with the same treatment. Does that make sense? Probably not. To talk about the different drugs which are available today, we have so many different types of inhibitors. Dr. Hellman spoke about the IGFR inhibitors and the mTOR inhibitors. There are c-Met inhibitors. There are tyrosine kinase inhibitors. There are other newer chemotherapy drugs. There are ALK inhibitors, PDGFR inhibitors, and the list grows long and longer. And so I want to talk about some of the treatments where they've used some of these therapies. And the first exciting treatment with a drug approved in sarcoma after a long time was a tyrosine kinase inhibitor called pazopanib, which inhibits a lot of vascular endothelial growth factor like pathways, where in patients with advanced sarcomas and relapsed sarcomas, there was a clear benefit to patients who received pazopanib versus those who received placebo. And this difference was both for progression-free survival as well as for event-free survival. There was another exciting drug, and this is the importance of doing clinical trials, where you had a specific monoclonal antibody called olaratumab, which targeted the PDGFR, or platelet-derived growth factor, and looked very promising, where there was this important difference in overall survival for patients who received olaratumab together with doxorubicin versus those who did not receive doxorubicin. And you can see they actually did a definitive trial, and just recently, 3 months ago, we got the answer that olaratumab probably didn't contribute too much. So this was a little bit of a setback. And so we've made advances to try and move this advanced molecular targeted therapy forward in pediatric sarcomas. One of our challenges is we've been quite successful with chemotherapy, radiation, and surgery, and so we wanted to build up on them. So we've actually done trials where we've looked at promising molecular agents like the IGFR antibody, genitumab, which is used both in Ewing sarcoma and rhabdomyosarcoma. Unfortunately, this is recent news as of last month. This trial actually did not show a benefit to adding on this antibody to chemotherapy. My answer to this is that we probably didn't do it in the right population, and there's so much more for us to learn. We've actually had other trials over here, and I'll show you one briefly in rhabdomyosarcoma and relapsed disease. And now we have a newly diagnosed study in rhabdomyosarcoma, which was built based on this trial. And then we had a trial in soft tissue sarcomas, and this included adolescents and young adults, again, all the way up to age 40 on this trial. And this trial was just closed with a very interesting result. And then this was the study, the Ewing sarcoma study, which the results were just released, which didn't show any difference. Then we have trials which are highly selective molecular targeted therapy, and Dr. Hellman alluded to larotrectinib, which is a very selective NTRK inhibitor, and there was a question of the audience, how are we going forward? Now, this drug not only worked in sarcomas where this was, but it worked in any kind of tumor which actually had an NTRK translocation. TRK. TRK is the protein, NTRK is the gene, so an NTRK fusion. And then there are other miscellaneous targets which are working, like TK216, which is specific against EWS-FLI1 in Ewing sarcoma. We have seclidemstat, which is an LSD1 inhibitor, which is being used again in relapsed Ewing sarcoma. And then we have a drug called tazemetostat, which is an EZH inhibitor, which is being used in epithelioid sarcoma, which actually didn't respond to anything. And now there are some patients who are actually responding to this. And this is the results of a trial which I ran through the Children's Oncology group, where we gave all patients with relapsed rhabdomyosarcoma chemotherapy with vinorelbine and cyclophosphamide, and we randomized them to receive bevacizumab, which is an anti-VEGF antibody, versus temsirolimus. And this trial was actually stopped early because it showed a superior benefit to those patients receiving temsirolimus. And now that we saw that this helped patients with relapsed disease, we've taken this drug and now we've moved it to newly diagnosed patients with intermediate risk rhabdomyosarcoma to hope that we can improve outcomes. So, what will the future look like? I think what's going to happen is we're going to have a cancer diagnosis. We're not just going to do scans and have the pathologist look at it. We're going to do a genomic analysis on it. And we're going to take all that information and what we know and then make a clinical decision, which is really for the patient. And that's what we call personalized medicine. I think I would like to say it's a little bit of a misnomer. Maybe the term should be precision medicine, since we try to personalize treatment for every patient, because each person is actually different. And so the shifting paradigm is where the previous approach was the descriptive medicine, and now we understand the disease and the mechanism. We had empirical diagnosis, but now we have a mechanism-based diagnosis for treatment. Previously, they were grouped by organ or site. That's why the big term sarcoma for 200 different diseases. And that's going to change, and it's going to be subgrouped by molecular targeted therapy. So we have fusion-positive rhabdomyosarcoma. We have NTRK fusion or TRK fusion sarcomas as an example. And from giving everyone the same treatment, we're going to be giving individualized treatments. And then previously, we diagnosed disease previously, but now I think because of techniques like looking at circulating tumor DNA and cell-free DNA, we may be able to pick these up on screening populations earlier with such precision that you could actually pick up cancer before it becomes overtly recognized. And that's probably going to be the way of the future. And I put this up as a patient example for a patient, and this was a 3-year-old child, but this is the same stories happened in adolescents and young adults with larotrectinib. As you can see over here, this is a tumor which occurred in the popliteal region behind the knee in a 3-year-old. There was no way any surgeon could take this out without an amputation. And to have a 2-year-old or 3-year-old have an amputation, we gave this child chemotherapy. And what happened? The tumor actually grew and got worse. And this child had an NTRK fusion, and we enrolled her on the clinical trial with larotrectinib. See what happened to the tumor. And the surgeon was able to take it out after just 4 months of treatment with clean surgical margins, and she has both her lower limbs, and she's running around and happy today as this 5-year-old, 5.5-year-old, with no appreciable, noticeable deformity other than a scar behind her knee. And she actually stopped treatment after the surgery was performed, so she didn't need any more treatment, and I think she's actually cured. So what are our clinical research opportunities? How can we improve outcomes? I think is very important till today. We are here to cure our patients. Are the ways we can have our patients live better lives, limit morbidity? How do we pick drugs to study? In which group of patients can we study these more efficiently? As we come into these molecularly targeted groups, the patients become rarer and rarer. So we need to change the bar of what we actually think is good therapy or not, and find out what's the best way to study them. And I still think that differences of lumping tumors is problematic in this day and age, and so tumor heterogeneity really needs to be considered in every decision we make. So in conclusion, the majority of sarcoma patients fall in the adolescent and young adult age group. We know that AYAs with sarcoma fare less well than children. Improving trends in AYA survival are not seen in patients with sarcoma to date, and we really need more data in the sarcoma populations with clinical trial enrollment, and that will give us opportunities to study biology, measure outcomes, improve supportive care, and address healthcare disparity, including access to clinical trials. I'd like to acknowledge my patients and families, which really motivate me to do what I do. I am very fortunate to work with an incredible multidisciplinary tumor team with surgeons, radiation oncologists, radiologists, nurses, pathologists, social workers, physical therapists, all who help to provide the great care we have for our patients, both at Children's Hospital and here at USC, and acknowledge funding from the various groups who have supported my work over the years. Thank you.
Great talk, Leo. Thanks. So Dr. Mascarenhas will be around a little later for questions. At this time, I'd like to introduce our next speaker, who is in the lab, actually, and does these genomic experiments and genetic experiments. His name is Dr. Troy McEachron. He's an assistant professor of research in the Department of Translational Genomics under USC Keck School of Medicine. Dr. McEachron received his PhD from the University of North Carolina, Chapel Hill, and completed postdoctoral fellowships at St. Jude Children's Research Hospital in Memphis, Tennessee, and the Translational Genomics Research Institute in Phoenix, Arizona. Over time, he has gained an immense interest and expertise in osteosarcoma research. While the genomic complexity of osteosarcoma has been well documented, the precise mechanisms utilized to initiate and or sustain this disease remains elusive. His laboratory is dedicated to understanding how this genomic complexity works and influences the tumor microenvironment, and in response, how the microenvironment supports the growth of these genomically unstable tumors. Oh, yeah. Additionally, Dr. McEachron's group is focused on integrating different technological and scientific approaches to analyze patient-derived material to better define the molecular characteristics of different pediatric AYA sarcomas to enable more precise treatment strategies as we continue to pursue precision medicine in these patients. So, Troy?
All right. Well, thank you for being here, and I really appreciate the opportunity to come and talk to you. So this is probably the most seamless handoff in terms of presenters, because Leo really set the stage incredibly well, talking about a variety of different targets, mentioned tumor microenvironment. Effectively, I should have just given him my slides, and he could have just done the job for me. So, I have a little bit to say, but I'm going to make this very, very basic, because as a scientist, we can go down the rabbit hole really, really quickly. And then I just don't want people to just walk out and be like, this guy's absolutely insane. So it's going to be very basic, but feel free to ask any questions when we're done. So we're going to talk about some opportunities for targeted therapies in AYA sarcomas, and really I'm just kind of going to work you through what this looks like at the laboratory level as opposed to the clinical level. But we have to remember that this is a team, so we are informed by our clinical colleagues. We just don't come up with a random idea and then go pursue it, because we want to make sure that what we're doing is actually going to come back to the patients at some point in time, hence translational genomics. So we talked about this concept of targets, right? So what is a target? And there's a variety of different kinds. We're really going to focus on therapeutic targets for the most part. So in the most simple way, we can just define a target as a molecule or process that is specific to or enriched in a cancer cell versus a normal cell. So effectively, what makes a cancer cell different than a normal cell? So what would make, a rhabdomyosarcoma cell different from the adjacent smooth muscle or skeletal muscle? Now, sarcomas, as Leo mentioned, we have a variety of different sarcomas, and there's quite a few that are actually fusion positive, meaning that they have this translocation. So for those who don't know, a translocation is just when two pieces of different chromosomes just kind of switch, so they swap. So blue, purple, chromosomes break, they switch, and now you have this translocation. So these would be ideal candidates because this only happens in the cancer cell. This does not happen in the normal cell. And then Leo put up a graphic or a table listing a variety of different fusions, and this is just another way to kind of visualize it. But here are a variety of different fusions or products of translocations that are present in sarcomas. So we can see there are a variety of different fusion genes that are present in sarcomas. So if these make ideal targets, that should make our lives a lot easier. We figured out the magic key, everything is good. The problem with this is that most of these fusions are incredibly difficult to target, meaning that we cannot actually design a drug that will specifically go after this fusion gene and inhibit its function. So although sarcomas or a fraction of sarcomas present with this great target, at this current moment, there's not too terribly much that we can do. But that's right now. Lee and Leo both pointed out that these TRK inhibitors are actually interesting, and there are TRK fusions, so that becomes one way in which we're looking at it. But again, that's one example in a multitude of different examples. So if we can't find, if we can't capitalize on these ideal targets in sarcomas, so what do we do? So that's when we get people like me who just really enjoy being upstairs and trying to figure this stuff out to come alongside and try to answer these questions. So the approach that we use is DNA and RNA sequencing. So just to kind of walk you through what that looks like, and this is what we use. This is the latest generation of nucleic acid sequencers. So what this means is that we will take healthy cells and we will take cancer cells. And we have about 3 billion base pairs in the genome. So each cell has around 3 billion base pairs. Each one of these little colorful lines is a base pair. What we do is we go we look at the tumor cells and we look at the normal cells, and we compare them base pair by base pair. So we want to understand, what do the base pairs look like in the healthy cells? What do the base pairs look like in the cancer cells? And are there differences? So to be able to do this, we take all of that digital information that we've got, that we've obtained by looking at the DNA in normal cells and looking at the DNA in cancer cells, and then we run this through a variety of supercomputing clusters, some of which we have here upstairs in the laboratory, and then most of it is actually at University Park campus in downtown. So we use all of this, we push all this information into a large computing cluster, and shortly thereafter, we're able to use a variety of different bioinformatic and visualization approaches to get something that looks like this. Now, mind you, this is not what a cell or tissue is supposed to look like. For lack of a better term, this is just a hot mess. This is a patient that I actually sequenced as a postdoc, metastatic osteosarcoma. This should not look like this, but the problem then becomes, I understand what this means, and I understand the implications therein. I can tell you a lot about the different copy number alterations, structural variations, point mutations, yada, 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 and again, go really deep down the rabbit hole. But then when I give this information to Leo or Lee or Dr. Who or James, they're going to say, okay, this is a really pretty picture, but what does it actually mean? right? So we get this beautiful high-dimensional data that really makes a lot of sense to me, but at some point we have to kind of whittle down to figure out what are the most clinically applicable things that we can actually get from this. So when we take this, we get to something like this, where we say, okay, well, here's a variety of genes that are mutated, and this is a paper that came out in osteosarcoma from a colleague up at UCSF. Took this information, identified a variety of genes, identified drugs that match them. Now we have targets that inhibit specific processes. So this is kind of how this concept of finding new targets and finding targets actually works. We have to be able to do something when, again, with sarcomas, the ideal targets we can't really do anything about, so we use this approach. So I'll just share with you an example of how we were actually able to do this in a tumor type for which we know pretty much nothing about. So we did a very similar process for patients with DSRCT, desmoplastic small round cell tumors. These tumors are rare. These tumors are incredibly aggressive. These tumors are intrinsically chemo-resistant. So what we did is we said, okay, well, we know something about DSRCTs. They have this fusion. Just like a variety of other sarcomas, it presents an ideal target, but we can't do anything about it. So using the approach that I just kind of walked through, said, okay, well, we're going to look at the DNA, we're going to look at the RNA, and try to get an idea to see if we can find out anything different about these tumors, and try to figure out if we can actually find a target that we can do something about other than this target, which is primarily just diagnostic at this point. In doing so, what we came up with is we found that this gene, IGF-2, is, for most of the specimens, is the most highly expressed gene, meaning that of all the 25,000 genes that make up a cell, the tumors decided to turn this gene on, this specific gene on, to such a high degree that it is the most highly expressed gene, which means that it makes a lot of protein. Luckily, we have the good Dr. Hellman, who spent a lot of his career looking at IGF signaling. Right? So there are as Leo alluded to, there's the IGF-1R antibody that didn't necessarily do well in the Ewing sarcoma trial. However, if those patients aren't expressing a lot of this protein, how well would it do? We wonder, would these patients actually do incredibly well because they're expressing high levels of the target? And there's also, I think Lee is working on the IGF ligand trap, so on and so forth. So this presents a target for a disease in which we don't actually know too terribly much about. We go on and we dig a little bit further, and we can see that in this plot, all this says is that there's about 50% of the patients who actually express high levels of one of these receptor tyrosine kinases for which there is a drug against, and then about 50% of the samples who don't really express high levels. This talks to the concept of molecular stratification, right? Would it make sense to treat these patients with a drug that's targeting this specific gene as opposed to these patients? These patients are likely the ones who actually receive benefit, and it's unlikely that these patients would actually receive any kind of benefit from going after this target. So those are targets that are specific to the cancer cell. But as Leo alluded, again, he should be up here giving the talk. Cancers don't grow in a vacuum. Right? You just can't say, okay, well, we have cancer, and it's this amorphous thing that's just floating around and doesn't have contact with anything else in the body. So the best way to really kind of think about cancer and think about the environment in which cancer lives and how do we actually target the environment, let's think about mosquitoes. So we're all very familiar with mosquitoes. They're pesky, they're everywhere, and if we try to go after every single mosquito that we see, we are never going to be effective at getting rid of mosquitoes and being able to enjoy barbecue. So what have we done? We figured out their environment, right? Why go after the mosquitoes when you can actually go after the environment in which they live? So rather than, sitting here looking like an idiot, slapping myself all day, trying to get rid of all the mosquitoes, I can go to the store or hire this person who I don't know and say, okay, we have some standing water around. Do you want to treat it? Shortly thereafter, mosquitoes are all gone. This is the same kind of concept that immuno-oncology is actually built off of. And when we're talking about targeting the tumor microenvironment, this is exactly what we're talking about. So what this means, if we take this analogy and then bring it a little further into the scientific realm, we're talking about immuno-oncology. So this asks just a couple of very specific questions. How does the immune system respond to a tumor? And in the same vein, how does the tumor respond to the immune system, right? So we know that these tumors do not grow in a vacuum. They are constantly just being in the presence of different immune cells, other different stromal cells, as we can see here. This is just a graphic kind of showing this interplay between different immune cells and tumor cells, so on and so forth. But understanding this dynamic relationship and understanding the environment in which these tumors actually grow, then we can come up with different immunotherapeutic targets. So in my lab, this is something that we're very much interested, especially in the context of osteosarcoma. So as an example, we just published this, where we use, again, this DNA sequencing approach, understanding base pair by base pair, the genomic landscape, or what genes are mutated in tumors versus normal cells. And we've realized that there's a handful, albeit small, but there's a subset of osteosarcomas, roughly non-overlapping, that have increased copies of some of these immune checkpoints. What that means is that these immune checkpoints tell the immune system, I don't want to be bothered by you right now, don't kill me, leave me alone, and I'm going to go on and do what I want to do. Now, so we've identified small subsets of osteosarcoma that have increased copies and high-level expression of different immunotherapy targets, which means that, or this asks the question, by stratifying patients, let's say these osteosarcoma patients, by specific targets or the presence of specific immuno-oncology targets, would these patients do better? We know from the studies out right now that most patients with osteosarcoma, metastatic osteosarcoma or advanced osteosarcoma, who have actually received checkpoint inhibitors don't really do well, but these patients were never stratified up front. So does this ask the question, would certain patients actually do better? Again, defining a target. Now, this is pretty much, when I go up in my lab, I just look at this and try to make sense of it. In doing so, what we've been able to find out is that this is actually looking at the genes that are involved in not necessarily osteosarcoma per se, but these are genes that are describing the environment in which osteosarcoma grows. So here we have in the gray, these rows over here are metastatic osteosarcoma, so pulmonary, and non-metastatic osteosarcoma, bone. By being able to understand the different environments between metastatic and non-metastatic osteosarcoma, we've actually come up with a variety of genes that actually seem to be really interesting in allowing these tumors to grow in very different locations in the body. And not only are these genes interesting, but there are actually drugs against these genes. And some of these drugs are actually doing incredibly well in the clinic right now. So that's pretty much what I do, and that's how we go through this process of finding and identifying targets. And I just would like to talk about one last thing. And my wife is an oncology nurse. And so what I do, it's really easy to be in the laboratory, have a great time, but I need to remember that on the other side of every specimen, there's a patient, there's a family, there's a community. So being able to do that, it's really awesome to actually have the opportunity to interact with patients because their determination is actually what drives us in the lab to be inspired. Here's a patient, my wife's patient, and I have permission to do this. I have it in writing, so don't, HIPAA and JCO, we don't have to worry about that right now. Championship dirt bike rider, 26 years old, gets Ewing sarcoma to the point where she couldn't do much of anything, and she was told that you need to get your affairs in order because it doesn't actually look good. And that was actually 2 years ago, and then this past weekend we actually got to see her get married. That's exactly the response you were supposed to have. It's fantastic. So this is what drives us to do what we do. So anytime, I have to walk through the clinic or walk through the waiting room to get into the lab, every time I see patients, this is exactly what I'm thinking of. These are the stories that we need, and my job is to make sure that we can get patients from the waiting room to here as part of a team with clinicians, social work, and surgeons. So with that, that's all I have to say, so if there's any questions.
Thank you very much. That was a great talk. Well, you can see that we're very, very passionate about what we do. And so in the next 5 or 10 minutes, we'll open for questions if you have any questions for Dr. Mascarenhas or Dr. McEachron.
I guess that I have to answer that question.
I can only speak to it.
It's a really good...
I do have some ideas.
So I think there are many ways about spreading awareness, and I think in pediatrics, most of us have grown up with the cooperative groups, and many of our patients are treated on clinical trials. And so I think our nurses actually do participate in that in some way. I think patients, really look to nurses to advise them because they're at the bedside all the time. So being involved with cooperative groups or through your nursing associations, I know you have SCAFON and AFON, and I'm sure that there are other ones, to really in each of those sessions talk about the importance of clinical trials and access over there and start a grassroots movement about it. So when you're over there, and then when you have to talk, nurses go the extra mile all the time, but we want you to go an even extra mile, and that is to really facilitate the other things which can happen at physical. Our first responsibility to the patient is their management. You want them to have the best possible care and the best possible outcome. But at the same time, to pay attention to, if there's an opportunity for a biology specimen, or if there's an opportunity to get a pharmacokinetic specimen, that all these things are critically important. They may seem mundane and extra work, but the information we actually get out of that affects not just that one patient, but affects generations of patients later. And we really help understand that. And the other thing is, oftentimes after we relapse, a lot of health policy people will say is that we are pushing ineffective therapies because our patients are going to die anyway. Why are you spending? And there are big papers saying the majority of healthcare dollars are spent at the end of life. But I think we learn so much, and our patients are willing to, to go through this with the hope that they may be cured and their families and everything. And oftentimes it doesn't work. But at the same time, I think if we learn as much as it and we can prevent this in the future, and a lot of them actually, a lot of my patients have come back and told me that that's, that in retrospect when they look back, they actually are grateful for that experience, which is something, which we see all the time and is actually very inspiring.
So, being married to an oncology nurse, I get that question a lot. You could marry a scientist. That's an option. I'm not available, but I have plenty of them upstairs, so you just let me know. But no, this is something that we actually speak about all the time. This is like our dinner time conversation. And what I actually encouraged her to do, I said, you have access to these trials, the documentation, read them. If you're going to present a patient with a trial, read the trial. Make sure you understand. Now, these trials are big, and to be quite honest, Leo writes them, so it's his fault that they're so thick. But I don't understand all the nuances of the trials, but I get the point, right? And I just try to help my wife to understand the point of this trial, why the trials are actually incredibly important, especially with the AYA group, as Leo demonstrated, that there's a huge drop-off, right? So there's a variety of reasons for that, the lack of participation in clinical trials. But again, I just encourage my wife to, as these new trials come up, read them. I'll walk you through it as best as I can, just so that you can actually be able to present to your patient not only the importance of enrolling in a trial, but what is this trial, this specific trial that you're presenting them with, what is that intended to do? What is the actual goal? What's the purpose of that specific study? And she's found that to be incredibly helpful, oftentimes boring. I enjoy it, but she's found it to be incredibly helpful in her practice.
Erwin Harris from Bakersfield. I don't think this is a trial issue. You left me with a distinct impression that this is a tissue gathering exercise with research and not a clinical trial. And I would be curious if our esteemed doctor could please just comment on the importance of having a virgin patient, if you will, or the initial patient, because well over 50% of these patients don't land in the hands of an institution like this until possibly after resection is already completed and the specimen has been discarded.
So you bring up a very good point. I think there are clinical trials which we call therapeutic, and those are treatment trials, but there are also clinical trials which are biology. So we cannot actually do research on a specimen without getting the permission of a patient. And there are two types of research. In the past, you'd have a bank where a lot of this was actually stored away, and the scientists would figure out something, but they did not have any of the clinical information to correlate their findings with. And so clinical trials, even for biology, or those on treatment, where it may not, what you're studying may not be relevant to what the treatment is, but at least we know these are the patients who did well, these are the patients who did poorly, and this is where we've understood the science. So now let's join that information together and make better decisions for our patients. I think in the community, it is a challenge. In pediatrics, we're a little more fortunate. The majority of patients have to be treated at an academic center in a central area where we can get these together. In the adolescent and young adult age group, and the older patients, oftentimes they are all managed out in the community. And for sarcomas in particular, Dr. Lee Hellman made the point, it's really important that you are treated at a center, a multidisciplinary center, where you actually have everything to go in place. I think Dr. Deepan, I saw him somewhere in the audience. In LA County, we have a tumor registry, and a lot of community hospitals actually discard tissue, but USC has actually gotten back that tissue instead of it being discarded, and are trying to correlate it with information coming from life registries and death registries. But those things take resources. So I think, there are many, many challenges, the access and care. I think our health policy needs to be looked at, because sometimes an insurance sends you to a particular place which may not be the best place for you to be taken care of. So these are truly challenges. And more education and awareness always helps.
I can't help myself. I can't contain myself. Look, I'm going to be honest. You know why every children goes on a clinical trial in the COG and adult stuff? How many private practice pediatric oncologists are there? None. You can't make money. It's too rare. What about medical oncologists? They do pretty well. There's millions of private practice medical oncologists. So it's a whole different system. And the insurance companies
I've learned since I started coming here. You know, sometimes it takes us, like Larry, it takes us 2 months to get an MRI approved for a patient. So there are so many issues. We could have a whole, but I do think most importantly, if we get our patient advocates to say, hey, this has to stop, and there has been some movement in insurance companies trying to pay for clinical trials, but it's a different playing field once you get past pediatric oncology.
Right.
There are no private practice, very few private practices. Once you get out in the real world, once you get to 25, 30 years old, you're most likely going to end up in a private practice, and that's their bread and butter. So why would they put someone on a clinical trial unless we make it worth their while? Because they see a heck of a lot more patients, as you said, than anybody in an academic center.
But I think there's some awareness, because I've seen this where we have medical oncology practitioners who do see a sarcoma patient and say, this is too much for me to handle, I'm going to send you out there. And so I think increasing that awareness.
They could do the clinical trial if we set it up right.
We could.
We have central IRB stuff. We're just not doing it.
So that's a big initiative of the NIH through the CTSU, as you know, and David knows this really well. It's been a struggle, even with making clinical trials available, because clinical research takes time. You've got to consent a patient, you've got to pay attention to all the regulatory stuff. And the other thing on the medical oncology world, as you saw in the slides, sarcomas are 2 to 3% of all the patients. When you have 20 times the number of breast cancer patients or prostate cancer patients or lung cancer patients, they say, why should I open a clinical trial where 5 patients can go on instead of opening a clinical trial where I have 500 patients who can go on? So they're making economic reason or a feasibility reason. And so this is the complexity of care in adolescent and young adults. And we need to address this not just in the lab or in the clinic. It needs to be addressed in society in multiple different ways. And I think our patients hold a key over here, patient advocates with the government, with their local congressmen, with advocating for funding, and it needs to be a movement.
Okay, well, thank you for that spirited discussion. It's lunchtime. Great job.
Good job.
I think the lunch is back there, right? Okay, so please, if you can be back here about 1 o'clock, we'll start the session again, okay? Thank you.